Thanks very much for inviting me along today. It's a pleasure to be here. We work very closely with staff in Harold's Cross and in Blackrock as well, so I would see that our care is an extension. I think in recent times there's been huge challenges and dilemmas regarding looking after M&D patients. And I was only saying to Mary when we were talking beforehand, I think sometimes from a palliative care perspective, that you see the most challenging and the most difficult of the M&D patients, because the patients, especially as in-house patients, because the patients that their families can manage are at home. And I see that everybody in Bowman, so we get a balance and we get that mix of seeing people who aren't so challenging and who aren't so complicated and having, I won't say an easier, but it can be quite different. But I do think sometimes that you get nearly a distorted view, because you definitely see the most challenging and the most difficult patients here and in Blackrock and palliative care services around. So I'm going to talk about what motor neuron disease is. It says ALS. It's called amyotrophic lateral sclerosis in every other country except England, Ireland, Scotland and Wales. So I sometimes flip from M&D to ALS. The other thing is that everybody here has a lot of experience. So if I'm talking about any, please at any stage interrupt me and ask me if you've got a question. I don't want this just to be a one-sided thing. It would be nice if we could have some kind of interaction and discuss any particular concerns or issues that you've had in the past. Okay, so we'll get started. So what is M&D? It's a relentlessly progressive neurological disorder culminating in complete dependence on others for all activities of daily life. The clinical management of M&D is palliative from the time of diagnosis. It's focused on symptom control and the adjustment to progressive loss of neurological function with the certainty of early death. We know that M&D varies from person to person. And it really does, like it can. We have sometimes people who are diagnosed and they're gone within 3 months. We have other people who have lasted 10 years, 15 years. So there's a wide range of people that we're looking after. I think the other thing that's very sad about M&D is that when we see people, whenever we see them, that today is as good as it's going to be. There's never a chance for remission or improvement or getting better. They're the best they're going to be today. And the only thing that varies from person to person is the rate of decline, and that's what varies. We could have somebody who, if we had 3 people diagnosed at Christmas time, so what was I saying? Oh yeah, just that the rate of progression will change. So as I said, you could have 3 people diagnosed at Christmas. By Easter time, one may have hardly moved, somebody else might have progressed, and somebody else could be on respiratory support, have gastrostomy. So that's what varies, and there's an unpredictability about that. But that's probably the best prognostic indicator that we have, that the illness tends to move as it continues. And if we have somebody who's taken maybe 18 months to get to the diagnosis and they've been to various different consultants and disciplines, it may not be moving that fast. Somebody that we see and is fast tracked into our service is actually going to die quite quickly. Commonest neurodegeneration of midlife, we really don't know what causes it. There's so many different theories, but we really don't know. I don't know if anybody saw Professor Hardiman recently on the news. There seems to be a connection with schizophrenia and other illnesses. We see Orla would take a very detailed history of patients when they come to the clinic, and time again we hear stories where families have a history of Asperger's, schizophrenia. We've actually had 3 patients, who've had schizophrenia and motor neuron disease. So we're learning more and more, and we've had our register is going. It's the longest register running in the world, actually, of motor neuron disease. So we've built up a huge bank of knowledge, and the more we're around a long time now as well. So we're building up a huge amount of knowledge and understanding that there's probably more going on than we first understood. The incidence is 2.6 and the prevalence is 1/16. We now know that there's an overlap of frontal temporal dementia. And I suppose any of you guys who are looking after M&D patients will say, how did we miss this? And the cognitive changes, because I think even though it wasn't actually identified officially, there's certainly a personality type that gets motor neuron disease. It's a disease of adulthood. We see some exceptions. It peaks around 50 and to 70. We've had 2 young patients, both a boy and a girl, who were 15, and they had a very rapid progression. Michael was a guy we looked after in Beaumont, and he was diagnosed in September and died in June. And at that stage, he was on respiratory failure, and it moved really very fast for him. The lifetime risk is 1 in 300 for all of us. So all of us have the potential of we have a 300 risk, which for what's considered a quite rare illness is high enough, really. The 70% mortality rate within 1,000 days of the first symptoms, all of our studies have shown that 70% of people will die within the first 3 years. The 30%, sort of all bets are off. It can vary, and some can have quite a long time, but 70% of people will be dead from the first, and that's very important that it's from the first symptoms. It's not from diagnosis. We have family history. There is a family history of motor neuron disease. There's about 15 to 20% of people in Ireland have a family history. We would have a number of families. We've got one family at the moment, and one lady is the 8th member of the family to be diagnosed with motor neuron disease. So there is, we have identified the one gene in particular that's been identified in Ireland as the C9orf72. We have the dilemma at the moment that we actually don't do pre-symptomatic testing for people with motor neuron disease. So if we have family members and they want to, their children want to be have genetic testing done, we don't have a genetic counselling service in present, which would be very important. But also the difficulty that we have, we don't know that if you get the gene, if you're going to get it, so that's another dilemma. And would it have impact on life assurance, mortgages? So it's a little bit complicated at the moment. So it's not that straightforward. And only last week at the clinic we had a girl who her mum and her aunt died, and her sister was diagnosed last week. And needless to say, she's quite worried. So she's come along to see Orla, and what Orla will do very kindly, and she has a few people like this, that she would just see them periodically, every 6 months, every 8 months, just to reassure them, because at the moment it can be a waiting game. They may never get it, but you can understand the anxiety that they have. So it's really important that we're there to support them as well. In Ireland, one person dies from MND every 3 days. So that's quite a lot. And the impact that has across, healthcare professionals and families. The symptoms of motor neuron disease will depend where it starts. You've got the upper motor neurons in the brain and the lower motor neurons along the spinal cord. And it's degeneration in the upper motor neuron and the lower motor neuron that leads to the problems with the motor function. So these are the things that we're looking for. So you go to pick up something, the signal comes from your brain down to your spinal cord, and then you can pick it up. When that signal is interfered with, you're not able to move, and that's why the person ends up being paralysed. The problem is with the nerve supplying the muscles, and most people will die from respiratory failure. These are sometimes some of the problems that we see, the symptoms. We see problems with speech, swallow problems, difficulties, being clumsy, limping, tripping, falling, and cramping. These are the symptoms that we sometimes see. Neuron science calls the slurred speech, the emotional lability, the spasticity, paresis, these decreased fine movements, and brisk upgoing planters. Now I think we have a mixture of staff here. I don't know if everybody is medical, are they? No. So I mean, these are just the things that when somebody comes to see Professor Hardiman, she examines you to see, and they help with the diagnosis of motor neuron disease. Lower motor neuron signs that we see are wasting. We see wasting in the muscles. We see weakness where people's power is down, and we see a thing called fasciculations. And everybody will probably go home today after listening to me talking, and they'll be thinking that they have fasciculations. You have these little jumping in your muscles, and we get them all the time. You might get a twitch in your face, but actually, if you were to pick up, I think sometimes you were carrying heavy bags or you were doing weights, sometimes the muscles flicker. But actually, fasciculations happen by themselves. It's fasciculations with weakness and wasting that's a worry. And interestingly enough, most medical students go along thinking that they have motor neuron disease. And I think every one of us in our clinic have often gone to get checked out, do we have it? Because you see something twitching and you think, oh my God, so don't be scared tonight. There is no definitive diagnostic test. So the things that we would do, it's listening to the story of the person, listen to the history when Orla examines them. We will do blood tests, lumbar puncture tests, and they're all normal. And we'll do an MRI test and a scan, and they'll all be normal. And that's often a very difficult time for the patient and the family, because they have this weakness, and it might have started something simple like playing golf and their drive is down, but they come along to see Orla, and they have a scan done. The scan is normal, and they think, oh, that's great, I don't have cancer, so it can't be very serious. And actually, as all the tests are coming back normal, we're getting more worried, because there's nothing to explain the clinical symptoms that we're seeing, that it's not MS. We do nerve conduction studies, and they're much more sophisticated now, so they can pick up on the changes. So we use that in as a support. I think sometimes when people come to see Professor Hardiman in the clinic as well, they're often surprised that they'll have gone around to see lots of different doctors, and then they come to see her, and it's how come she can be so sure that this is what it is? Now that's obviously down to a huge amount of experience, and we would always keep an open mind as well, and review people if they're not changing. But for some people, sometimes coming to the clinic, they're coming for a second opinion, but they're actually hoping this isn't what it's going to be. And then there's the fear of how come it seems so easy for her then to diagnose it. MND is really a series of losses. There's loss of control, independence, security, people's identity, their role, their status, their self-esteem, their body image, their sense of attractiveness, their opportunities for privacy and intimacy. And I know when you're caring for people here, they need so much equipment. I mean, the idea of not being able to do absolutely anything for yourself is just absolutely terrifying. And this probably applies to other illness as well. It's their loss of their friends, their work colleagues, and the extended, their family and their future plans and ambitions. And the unpredictability of the illness and what's going to happen to them. And M&D always has a bad press. If it's on Holby City or Casualty, it's always an M&D patient who wants to go to Dignitas or who wants to end their life. So there's always a scary element. Have you come across that of M&D? For many people, what began as a minor symptom was turned into a disabling and fatal illness for which there is no cure. And if you can imagine, if you've got somebody coming in and they've got a weakness in a leg or just their arm is a little bit weak, to go through the series of investigations and then to be told that you have motor neuron disease is pretty devastating. And I think this is just important to say, that the impact of the illness it's a unique and individualised experience. It's influenced by how the patient and the carer perceive the changes caused by their illness, the previous coping mechanisms that they have, the presence of support structures, and the strength of their relationship prior to the diagnosis. And really what I mean about that is, we have a young guy a few years back who was diagnosed. He just has a weakness in a hand, but actually he was a professional rally driver. So for him, his career ended immediately. We have some people who are living on their own, and that has an impact. And we have a couple at the moment who were probably in the process of splitting up when he got the diagnosis, and now they're forced to stay together. So that raises different challenges and different stresses for families as well. So it certainly challenges the person to unlearn the mastery of the body, to unlearn personal control and independence, and to return to the state of complete dependence, which I find absolutely terrifying. Features that we know that relate to prognosis. We now know there was a time, and there's lots of books out there, and I mean, we did it ourselves in Beaumont. When people got the diagnosis of motor neuron disease, you'd say, this is a terrible illness and we're very sad. The good thing about this, though, is it doesn't affect your thinking, and we were so wrong. We were so wrong, but that was actually the story that people were told. We now know that that's not the case. We now know that there's changes in the brain, and over 51%, or 49% of people have actually cognitive and behavioural changes. So that actually makes it a very different and a very challenging illness to be looking after. The bulbar versus spinal. Bulbar is where you present with speech and swallow problems, and spinal is you have a weakness in an arm and a leg. The bulbar patients don't fare so well. They have a prognosis of about 6 to 18 months because the respiratory muscles get involved, so they die quicker. And the spinal onset, for them, the illness can be quite protracted because you're in a wheelchair, and it's quite sad sometimes. People will, they'll come in maybe with a weak leg and they're using a stick, and then they progress onto crutches, and then it's a wheelchair, and they'll say, gosh, don't mind if the legs go, but I don't want the hands to go because I can do a certain amount if I have the hands. And the hands will go, and they'll say, gosh, I don't mind if the hands go, providing I don't lose my voice. So the thoughts of losing their voice. So there's this constant shift all the time of people accepting things and moving forward. And I think for the family as well, and I'd say you guys come across this as well, that people get on top of the illness and where it's at, and a couple of weeks later or days, everything shifts again and you've got to start again, and it's soul destroying and it's exhausting for people. The age of onset as well will vary. I mean, the two young people that we had moved very fast, and we're now having a much older population. We've had people in their 90s diagnosed, and that raises different challenges as well, because if you've got maybe an elderly couple living together, they're physically not able to look after each other. So different ages raise different challenges for people. We know that with respiratory function, sometimes people, the first thing that affects them is their respiratory function. And if that's the case, they're going to move very fast. We had a gentleman who was, a few years back, he was skiing in the end of March, and he noticed weakness. I mean, he was obviously very fit skiing, and he was lifting his bags and felt he didn't have much power, and came back, went to be investigated, and he was feeling quite breathless. He thought he was getting on, and he thought he did too much skiing, but he was diagnosed at the end of April, and he was dead in June. So it can be that fast for people. And we also know that your nutritional status has an impact on your survival. Now, obviously, if you're not able to swallow, it's going to affect your caloric intake. But we also now know as well that some people that have respiratory problems, they have a hypermetabolic rate where they're, no matter, even if we support them from a nutritional point of view, we can't get them to maintain weight. And if somebody is losing weight very fast, that's a bad sign. The illness is moving quite fast. The glasses on, I can't see the computer without the glasses. I'm going to focus a little bit on the cognitive impairment, because I think that's where most of the challenges come from. And please feel free to interrupt me. We feel that it's very important. As I said, I'm part of a very big multidisciplinary team at Beaumont, and we have neuropsychologists working with us all the time. So everybody that comes to our clinic, we have them assessed using the ECAS, it's the Edinburgh Cognitive and Behavioural Scale. So that means that we can pick up on subtle changes, and if we find them, then we can do further neuropsychological testing. So this helps us to understand. Now, at the moment, it's kind of like this is an in-house thing, because we're trying to work out with Professor Niall Pender how we can filter out this information for everybody else to be aware of. It started as a research programme, so we have to be careful about disseminating information about patients. So we're trying to look at that, because it's like as if we nearly have a disadvantage, so we need to be able to share the fact that these people are having problems. The cognitive impairment is classified. I think it's really important to remember that 49% of MND patients don't have these problems. But you may not be seeing that group of patients, because actually their families are able to manage them, and they're easier to be managed in the community. The cognitive impairment is divided into executive impairment, non-executive. I'll talk about what these are. The full frontal temporal dementia is like a complete dementia. And if there's any mathematicians in there, you'll see that only adds up to 99. So the 1% is where there's other comorbidities and other things going on. The range of this can be from very mild to very moderate to severe, and it can be evolving. And I think that's something that we didn't even realise as well. We have a gentleman living in Wexford at the moment, and he's been on NIV for about 5-6 years, and he's kept alive because he's on non-invasive ventilation. I'll talk about that as well. But he was quite no problems, and would have been categorised normal. At that stage when he was diagnosed, we weren't doing these screening tests. But as the illness has progressed and he's been kept alive with respiratory support, he's now developing the cognitive changes as well. So it's very interesting for us to see this, so that it's some people, they present with it, and sometimes the frontal temporal dementia patients, that's the first things that they come along with. But it's also, we need to be aware that it's an evolving thing, so there's continuously changes happening. And we have a big study going on as well, looking at changes in the brain, and we're having PET scans done, and we can actually correlate the changes in the brain with the personality changes that we're seeing. So this is really very interesting. The executive function, so that the way that impacts on patients is it affects them from an attention point of view, from a planning point of view, from a regulation. So they're not able to do all these kind of things. And it's really important that we understand what's going on, because it should influence how we engage with people all the time. But we need to be aware of this. And it certainly didn't help when you had us as the experts saying it didn't affect your thinking. And now we know that it does. So we're kind of trying to undo. And I nearly think, because I've been around for a long time, there was, certainly in the early days, there was lots of patients who we can now say, gosh, definitely they had this behaviour, and we didn't know. But not only did we not know, we weren't able to explain to their family that their behaviour was because of the illness. So we need to be kind of sharing with families as well that people have lost people many years ago, that actually their behaviour wasn't their fault, that it was caused by the illness, because I think that's really important. They can also have problems with language. It's very interesting. again, and we see it in the clinic, people have problems finding words, like you say, what's that? And they're looking at it and they'll say it's pen. Now, at some level, they know it's not a pen, but they can't find the words, and this impacts on their comprehension. Now, Leslie is our speech therapist, and she's got a lot of experience in this. So we really do very detailed tests on people. And sometimes as well, people will present initially with memory difficulties that actually they can't remember. And they can be functioning quite well. And these are very subtle. We had a lady recently as well who came along with her husband. And following the diagnosis with Orla, she just broke down in tears because she spent the last 2 years going to see different consultants and nobody was quite understanding what was going on. So it was really important that Orla was able to say, this is it, because what she said was, either he's losing his mind or I'm losing my mind, and I'm not sure which one of it is, because she said he's not right and nobody's listening to me. So bad knowledge is getting the diagnosis. Sometimes it gives you somewhere to start, and that we know what we're dealing with, and that can be very useful. The way it impacts on behaviour, and these are the things that we've seen, the apathy. Some patients are kind of just completely disinterested, you know, and sort of sit back, and it can be very easy to manage. I mean, they're the people that will just do what you tell them to do. The other challenges that we see from behaviour point of view is the reduced awareness of insight. They've no idea of how the illness is impacting, especially on their family member or their carers. Like, we'll be trying to get carers in to give them a break, and it'll be, sure, what's the problem? There's no problem in mind in me. Like, I'm just here. And they don't realise it's 24/7. Person is not able to go to bed. We had a gentleman who was on the NIPI support for 8 years, and we had a good care package going in, but actually he wouldn't allow his wife go to bed until about 1:30 or 2. They had 4 kids under the age of 7. And he also insisted that she would sit and hold his head because he was afraid his head would fall. The OTs did a great job coming up with all sorts of devices to support him, but he was still very controlling, wanted her always to be with him. And no matter who we got in, she had to be present. So she was absolutely exhausted. And I remember her saying to us that, if she'd have known that he was going to live, he lived 8-9 years, that she would have done things very differently in the beginning, because when he got his diagnosis, he was young, and she felt, well, this is going to be short, so I need to mind him and I need to do everything for him. But then that set up an unrealistic expectation that he had, that she was going to be there. So sometimes we maybe now need to get external people in to help the family so that we don't add into that atmosphere. There's the rigidity. Any of you that looked after people on the ward, they have a cup. I don't want it there. I want it there. I want my pillow moved. It's not right. You could spend hours, literally hours, and you're never going to get it right. And interestingly, we see overeating and food fads where people change. I was out visiting a house with a patient out in Dalkey, and in fact she was familial as well. Her brother had motor neuron disease, and he had a spinal onset of weakness in an arm, but she presented with the frontal temporal dementia, which probably means that this family had the C9orf72 gene. And they used to have video nights on Fridays, and they would get sweets and biscuits and lemonade and just have a family evening. And her husband said that she had turned into a miserable old bitch because she was going to the shops, buying treats, stashing them. They were all upstairs in her bedroom, but she wasn't sharing them. And the other thing that she'd started to do was she had a fabulous, like a massive big bedroom that was converted into her walk-in wardrobe. It was to die for. And when he started caring for her and looking after things, she had shelves full of white t-shirts, black t-shirts and khaki t-shirts. He brought me up to show them. They were all from Marks and Spencer's. And it was like a shop. She had about 50 of the same t-shirt, never worn. Now, it was good for us to be able to say to him, this is the illness that's causing these changes, because he felt that she was rejecting him completely. So for him to understand that it wasn't her fault, that this is the illness causing the difficulties, is really important. We see the blunted emotions, and that can be very hard for people, where they kind of just switch off. They're not engaging with the family. The wailing, we see emotional lability, where there's an uncontrollable laughing and crying. Now, the crying can be really, really upsetting, where people are just wailing all the time. And I know the guys over in St. Francis had difficulty with a lady like this, and I think you guys did here as well, where these people are wailing. It's actually very upsetting for other families as well who are visiting people, because it looks as if these people are being neglected. But you could spend 2 hours with them and you walk away and they're looking and being demanding again. I was in a nursing home recently because the staff are literally falling apart looking after an MD patient out there. Really very challenging behaviour. He was racist and abusive and didn't want any non-nationals looking after him. And the girls were and the guys were doing their best. And then he'd walk away and they could spend hours with him. And it was particularly challenging at night time when there's less staff on. And like he was saying, well, I'm paying for this. I want this. I'm entitled to this. I'm paying. You're getting, fair deal, and you've got my pension or whatever way it works. And so that lack of insight and that lack of understanding is very, very challenging. The impulse buying, I talk about the lady, I'm repeating myself here, lack of empathy, the hoarding. There's a huge obsessive compulsive disorder element with motor neuron disease patients. And you're probably thinking, yes, I remember, because these things are things. And that's why you kind of think, how did we miss this for all these years? There's change in personal hygiene, and there's an onset criminal behaviour. We did have a family before where there was a gentleman diagnosed again with spinal. He had weakness in legs, he was in a wheelchair, he progressed to have respiratory failure, and then he passed away. A couple of years later then, he had a brother who presented with speech and swallow problems. He was in a pub having a drink up in Tala, and the more he drank, the worse his speech got. And somebody was taunting and slagging him in the pub, and he went home to get a knife to come back and get them. But he actually didn't make it as far back as the pub. He stopped at the bus stop and he murdered a lady who had nothing to do with him at the bus stop. Now he ended up in the criminal hospital in Dundrum. The family completely disowned him because they just couldn't deal with this. And at that stage we didn't know what was going on, and that's what I'm saying about us nearly needing to revisit families to explain that actually this wasn't his fault. He had no control over this, that it was the illness. But then that has implications for them because it probably is of a hereditary type. So if you have something like this going on in the family. So is it important that we know about cognitive impairment? It does have an impact. It has an impact on survival. We know that if you have cognitive impairment, you may not survive as long as other patients. It certainly has an impact on decision making. So the ability to completely engage or to competently engage in end-of-life financial decisions may be affected. So all the time, we're trying to include these patients in all the decision process that we make. Advanced care planning, care plans, using wheelchairs, and sometimes I come out and you think. You'll meet with them a week later, and it's like as if you never had a conversation. And sometimes you begin to doubt yourself. Well, maybe I forgot. Maybe I didn't say it. So we're trying to have very challenging, conversations and plans with people who aren't capable of doing it. There's a huge problem with compliance. I actually don't like the word compliance. I think sometimes it implies if we haven't explained, but I don't have a better word for it. Where there's reduced adherence to medical treatments. From using a NIPI point of view, for using the gastrostomy. And if people have cognitive impairment and have problems with their word finding, they're not going to be able to use the AAC is the communication devices we use. I mean, I think everybody's familiar with Stephen Hawkins and his voice thing. We're using eye gazes, but if you have a problem with processing words and with your cognitive, you're not going to be able to use these. So that adds to other problems. And very interestingly, we see people who may be exhibiting. Are there any dietitians here? Not there. We sometimes see problems with people reporting and the family reporting that they're having swallow problems. But actually, the swallow problem for some of these patients, it isn't actually from a swallow from an anatomical point of view. It's actually cognitively. They eat and then they forget to swallow, and the food is in their mouth. So we need to be aware of this as well from that point of view. From the gastrostomy point of view.
Sorry, just clarify what NIPI.
NIPI. Okay, NIPI is non-invasive positive pressure ventilation, and it's shortened to NIV. As I was saying before, no, it's non-invasive, so it's a mask attached to. I have a picture of it later on. It's attached to a machine. People die from respiratory failure, so if you can imagine what happens. When you take a breath in, you have the muscles, the diaphragm and the muscles along here, and they all work because the nerve supply is coming to the muscles. So if the nerve supply is stopped, the muscles stop working and you can't breathe. And it's quite distressing, and that's how people die. The way the NIPI works is, if you're running into problems of being able to breathe, you put a mask on, you take a breath, and under pressure, it forces air into your lungs, and then you're able to breathe, because there isn't a problem with the lungs, the problem is with the muscles. So that's why the NIPI machine works. Non-invasive just means it's a mask. We don't use a tube to, keep you alive on a machine. And we would use that. We actually use, when we set people up on the NIPI machine, we use that as our criteria to refer to palliative care. If we had our way, we would have palliative care from the time of diagnosis, but given the lack of resources, that's our trigger for getting palliative care involved, because if you can't use the NIPI, you might need support from a palliative care point of view, from a medication point of view. So that's our trigger. I'll talk more about that. So sorry if that was confusing. The safety awareness, people that have these problems, people that have these problems, aren't going to be aware that they're falling and the choking episodes. So it becomes a 24-hour job looking after these, and there's no doubt about it that there's a huge carer burden impact when people have cognitive behaviour. Not only on the families, but I also think on us as healthcare professionals. And I think that's where the challenges are coming from. And I think it's really important now that we understand what's happening, because, if we need to understand and manage and plan, it makes a difference knowing that this is what's happening. Does this make sense? Is it just... We did recently, we got funding and we did a KEDS, which was just a knowledge and exchange. But what we did, we had a pilot group. We actually used the guys in Blackrock. We used their multidisciplinary team, and we got them together just to get some feedback from the challenges that they were having. We had bereaved families of people come in, and it was really very interesting because they talked about the challenges that they had. I have a few little scenarios that I'll talk about. And we had family meetings that we did around the country, in Dublin, Athlone and in Cork, where we had families come together to help to share with us the difficulties that they had, so that we could start maybe approaching our care differently. We have a booklet published now for healthcare professionals. I've none to bring today because they're all gone, and they're going to print again, so I'll get some sent out to you. And we're working on one for the carers as well, because, as I said, understanding what's happening really changes the way we engage with these people. Out of those meetings, what came up for us was that the behaviour changes pose the most problems. I think if you have full frontal temporal dementia, that's nearly easy to manage, because it's the behaviour, and if they're very subtle, like somebody can be functioning quite an okay level, but they're just slightly off, and they don't, refusing, they're told not to drive, but sure, of course I'm going to drive. How can I get to the shops if I don't drive? These kind of things. And sometimes it's hard for the family to pick up as well that there is actually a problem, because sure, daddy's always done that. Or, if, especially around the driving. We had a gentleman, actually the lady, who was really glad that her husband was diagnosed, but the rest of the family really struggled with the idea that her dad, her husband and the dad had to be told not to drive. And they were saying, but sure, he won't function if he can't drive. And I said to one of the daughters, she had at the consultation, she had a 2-year-old sitting on her lap. And I said, would you put your baby in the car with your dad without you being present? And she said, oh no, my dad's not allowed to drive with the children in the car. But he was allowed to drive and endanger the rest of us. So these are very interesting things that happen. That the caregivers and the families need help, that the caregivers need additional support from the clinical and community terms to understand the behaviour. They need advice on how to manage the behavioural problems, to learn coping strategies, definitely more information about the condition and how to cope with the future, and the opportunity to ask questions. It was interesting, most of the carers said that they would love to meet with us as healthcare professionals on their own without the patients being present, because they feel that they can't really discuss what they want to discuss when they're there. Now, we're going to try and do this in the clinic, but it's very hard. Our clinic is mental. We don't have enough rooms, but it would be very nice if we had some time for the carers, because they feel that, one, they feel they're being disloyal if they're giving out or complaining, and other times they just need that space themselves. I was saying earlier about introducing formal outside carers. They certainly felt that that would make things a little bit better if that happened much earlier in the disease process, that you end up having a carer coming in beforehand. Because what happens is the family are saying, we manage, and it evolves, and then it comes down to one person or two people in the family who are doing all the care, and then the person is going to object to any other carer coming in. So that might help. Yeah, just about that, they would like time to talk. And they certainly felt as well that network and focus group meetings would be useful for information exchange. They sometimes can work. We had difficulty before. I work closely with the association as well, and they tried to have group meetings where there would be, patients and families come together for support. I was there one night with them, and we had a lady who was diagnosed, probably about 15 or 16 years, who overtook the whole session. And her attitude was, I'm here because I have a positive attitude, and if you have a positive attitude, you're going to be okay. And then we had another lady who was diagnosed 6 weeks, who had a rapidly progressive type, and she's thinking, I'm getting worse because I'm not positive. So without being, paternalistic and mind things, we've got to be careful, because sometimes strong personalities. So I'm not sure what the answer is to that. These are just some of the clinical scenarios I thought might be interesting, and I think again you guys might relate to this. This was a guy who was 39, he was single, he lived alone. He presented with a weakness in his thumb, which again, just to present with that and then to get a diagnosis. He was an IT programmer. He was diagnosed in October 2013 and he died in September 2015. His sister and his brother were his main carers. His mum and dad just couldn't cope. He had a full home care package, plus the grant from the association, and he fired every single one of his home helpers and carers. Nobody could get it right. The carers were physically and emotionally exhausted. Everybody struggled despite their best efforts to keep him comfortable and to keep him at home, which they didn't manage to do. He had to be admitted to St. Francis Hospice because it just wasn't possible. And there was a terrible sense of failure amongst the carers and the family that this was, but they couldn't cope. His sister actually had a nervous breakdown after he died. It had such a terrible impact on the whole family. Now, his behaviour was very manipulative, and it was very interesting that when he came to the clinic, he was the nicest thing since sliced bread. I mean, he was just charming. When he went home, the carers, he was abusive, physically and verbally abusive to the carers that were coming in. And I said to him, if you spoke to me, I said, I just wouldn't come back. I said, I'd just leave you there. And he said, well, you can't just leave me. And I said, well, actually, they can. We have to remember that we have to protect ourselves as well. He was extremely controlling. He was very aggressive, frustrated and irritable. And I think what we did in the past, because this illness is so devastating and people are losing so much control, that we were nearly forgiving this behaviour because, they've got a short time to live. They're losing everything. So we were explaining away the control over certain things as because of what the illness is. But actually it's not. There's changes happening in the brain. As I said, he was verbally and physically abusive. He was so OCD, you just couldn't get it right. And the really very sad thing was when he went into the hospice, despite everybody's wonderful, wonderful care, he went on social media and to everybody and whoever could find it to give out about every single carer by name that went into his house, and that he'd been abandoned by his family and that this is what his family had done to him. And I think that was the final straw for his sister then. So it's just being aware of how difficult and challenging they can be. And this is what came out when we had the family sessions, come together, that the families, talked to us about this. Not that we weren't aware of it, but they were very happy for us to include this information to see if it will help everybody else. And that's why I think I'm really happy to be here today, because we're learning so much that we need to share this to help everybody else in dealing with MND patients in a different way.
How did you help the staff in St. Francis when they had that patient in? Because that would probably relate to...
I get to that.
Okay, sorry.
And I don't have all the answers either, Mary. That's the problem. The other case was an 80-year-old retired CEO company. His initial symptoms were memory loss, and obviously a very high-flying, intelligent man. He was very successful. His problems, actually, the first guy, when we did the ECAS on him, his ECAS was normal, which is interesting to show that he evolved to have those behavioural problems. This gentleman, his ECAS was abnormal. And he presented with the behaviour of apathy, complete disinterest in everything, lack of insight. And for somebody who was a very, very smart, intelligent man, this was a huge change in his personality. He was completely reckless. He was used to go skiing, and he still wanted to go skiing. But when his daughter had him in the car and they stopped at the traffic lights, he just wanted to get out. So, and this man, I think he's about 6'8". He has a wife who's about 5 foot. He's a huge, big physical presence. It's so difficult to contain him. Again, fixating on single items and activities. If he just wants to do something, you're just not going to stop him. He wants to do it. His inability to concentrate, lack of judgment, and going back to memory again, difficulty. He'd start to do something, forget to think what he's doing, and going off again on something else. Huge care burden for his wife. Now, they're very fortunate from the point of view that she said again at this meeting that she needs to preserve her own physical and mental health, and how can I do that? And she was conflicted because she promised him when he got sick that she would look after him and keep him at home to the end, and she can't let that promise go. Now, they're in the very lucky position that they're financially well off, so she has carers 24/7. So that makes her, but that's not everybody else is going to be in that position. Yeah, but this is a lady who lived alone, spinal onset, weakness in her legs. She was diagnosed in 2015 and died in 2016. She refused to do the ECAS, and we often see that with people who are cognitively off. They're actually refusing to have the assessments done. Now, we're getting better at spotting people. Hindsight's a wonderful thing now after all these years. But often, though, they're very people who won't want to do it. So that. So she refused to have the ECAS done. She had 24-hour home care package. It was supplemented by private funding on the grant. And again, the same kind of scenario. Nobody ever got anything right, just couldn't get it right. So she was hospitalised. And again, the behavioural stuff is the poor insight. Again, the complete lack of empathy and understanding for how they're impacting on staff and other people around. Very, very controlling, very manipulative. This lady was so racist, it was unbelievable. And I mean, that's just not acceptable behaviour. She was abusive, again, physically and verbally. We had one lady years ago, and it was about 20 years ago. And again, this is kind of us, it's like putting pieces of a jigsaw puzzle together. The picture is beginning to make much more sense to us now. But when her husband, when he was able to, he used to kick her. And then when he stopped kicking her, he used to punch her when the legs weren't working and the arms. And then when his arms and legs weren't working and she was doing something, he would headbutt her. And it actually went that he would bite her if she was close to him doing anything. And we didn't know what was going on then as well. So this lady was extremely abusive, very demanding. And I think the other thing, we saw this on the ward as well in Beaumont with a lady who, they're very divisive. They're very good at splitting staff. And I've seen this in the community, and I've seen it in Beaumont, and I've seen it here in Harold's Cross as well, where you'd have somebody, and all being human, they kind of think, you're the best person, you're the only one that gets it right for me, and the rest of us are feeling like complete and utter idiots that we can't get it right, and they end up setting staff against each other. So it's really important. I mean, you're nodding, this is happening to you guys. Yeah.
We haven't made that one last course.
Yeah. Does it help hearing that? Yeah. And it's very difficult to do. I mean, actually, there was a lady out in the north side, and I'm old enough to remember old sort of Dracula films where Dracula would have the lay person looking after him because he had to be kept safe from the dark or the light. So he always had to have a nun-vampire looking after him. And this lady kind of reminded me of that because she had this one carer who, with the best intentions in the world, would call in after our hours. She'd be going to do her own shopping. She'd drop in to see if she was all right. Nobody could get it right. And this lady was completely and absolutely manipulating this carer. And then she was getting extra carers in. And the good carer had to vet other carers who were coming in. And I was in the house one day, and she was saying, you're not coming to see her now because she doesn't want to. And I said, well, this girl has travelled to come and meet her. So she has to come and see her. Well, she doesn't want to. And I said, she has to. She just has to. Now, that person was doing it out of goodness and kindness and trying to get it right. And I don't want to be critical of her, but it's very easy to kind of get caught up in that trap. And I think, we have another lady as well who's ventilated around the country. She wanted to be electively ventilated. Now that's put on a machine where you have a tube down, tracheostomy in, you're kept alive on a machine, and you'll be kept alive indefinitely with motor neuron disease, and the illness will continue to progress. We don't electively ventilate people in Beaumont, but they did in another hospital. This lady refused to use any communicating device, and at this stage she could use an eye gauge. She's quite a clever lady, but she refused to use any communicating device until she was in intensive care unit for about 2 months, 3 months. So then she decided that she wanted to learn to use the eye gaze, and the thing she wanted to learn to use the eye gaze was because she wanted to complain about specific staff. So she learned to communicate, and then she named staff that she didn't like and who weren't doing things. So we need to be very mindful that we're protecting staff and minding people, and this is the behaviour that goes on. So the impact on healthcare professionals. So the cognitive and behavioural deficits are extremely challenging for us. They're associated with reduced adherence to medical treatments and compliance with multidisciplinary care interventions. It certainly heightens distress, huge increase in sick leave. People don't want to come to work if you've got to look after somebody like this. And if you're in a unit where perhaps that's your job for the day. And what we actually advised with the guys in Raheny was to rotate. And we've done the same in the intensive care unit, that actually you can't have some members of staff or any members of staff looking after somebody for a long period of time. We need to break it up, and to try and avoid this behaviour of you're my favourite and I only want you. And when this was happening in us in Beaumont, and nurses were saying, well, I don't mind. Well, it's not that you mind. It's actually not fair for everybody. It's not fair for them. So we were rotating sort of on a 3 or a 4 hour cycle. And then the patients are saying, well, especially if you're in an intensive care unit and there's only 3 or 4 people, it's very easy to observe. They say, we're finding this behaviour challenging. This is what we're going to do. You include them in what you're doing, but we've got to protect ourselves. We can't have staff, being treated like this. The nursing home that I went to, there was 2 lovely Filipino nurses, and they were in tears when they were listening to me talking about this, because every night they were getting abuse, which was totally unacceptable from the gentleman that was there. It's just not acceptable. It's impossible for us to engage as well and develop care plans for people who actually can't process. So we're going along to, advanced care directives, end of life decisions with people who actually aren't capable. And it's not that we don't want to include people and people don't have their autonomy, but actually they're not capable of having these discussions. They can't concentrate, they can't plan, they can't organise, they can't reason, and a complete lack of understanding. The other thing that we've seen as well, that with the cognitive stuff, is this in addition, where patients will have difficulties with impulse control, again the risk assessment, reckless driving, irritability, anger outbursts, physical and verbal. Sexual inappropriateness is often very difficult for other family members if their dad usually is sort of sexually inappropriate. I went to a house one day, and I'm very old and I've been around a long time. My daughter's a psychologist who's doing some work with her at the moment, and I think of her going into the house and how she's 23 and how she would be able to cope. But I went in and the wife said, he's upstairs, I've had enough of him, and he's upstairs in bed. And I went up and he's in bed, and he's just a sheet on, he's no clothes, and as I'm talking he keeps pulling the sheet down and pulling the sheet down and pulling the sheet down. Right. So I just got the sheet and tucked him in and said, now you're going to get cold and you need to stay nice and warm in there. But actually I'm not sure if it was the young psychology people that we were sending in and they were alone, if they know how to, which is quite inappropriate. We had with our poor Leslie, our speech therapist, was assessing one of the gentlemen, one of our patients recently on the board, and he was masturbating and he's in bed. So it's very important that we know, and family members are absolutely so ashamed and embarrassed, and again that we need to explain that this is the illness that's causing that. This is a complete change in somebody's personality. Again, the manipulation and the divisive behaviour. And I think the difficulty for us is that we're conflicted because we want to provide good, effective care to these terminally patients while protecting ourselves. And I think sometimes we can confuse being firm with being mean. But actually we can be firm, have a good care plan in place that's quite acceptable, and to realise that actually, the screaming and the shouting and the demanding, it's always the same. The people that shout the loudest get everything, and we often need to be mindful of the people who are very quiet. So if somebody is shouting and screaming and roaring, somebody else is getting neglected. So sometimes it's a case of sort of explaining to the patient, no, the other thing as well that M&D patients are very good at doing. Now I sound as if I'm completely anti-patient, and I'm actually not. I really amn't. Is that they, especially people who can't speak, and it was the girls in Marymount raised this with me a few weeks I was down there. They're saying, if you've got somebody who can't speak, so they're using a communicating device, it takes hours, and they insist on spelling every single word out that takes forever. And they were saying, you have a specific amount of time. So are we going to, we were saying when we decided that probably the good thing to do is to say, look, we've got half an hour to get you up, get you dressed, get you sorted. We can't spend a half an hour, waiting for you. Perhaps let's do what we need to do. Then you can type all this in, and then maybe I can come back later. And start developing strategies like that so that we have time, to go back to people. And be firm and say, look, I'm sorry if I'm not getting it, and I know you've got lots to say, but actually I only have this amount of time, I need to do this, but I will come back to you. And we've started doing that in the clinic as well, because we don't have time, that if people are coming, that we'll say, make a list, print it out from your iPad or whatever you have, so that we can actually go through it. Because and then they'll focus. They could have a list this long, but they'll focus on one thing, and we don't have the time. And it's not that we shouldn't be giving time to people, but I mean, busy wards, everybody has to be looked after. So sometimes thinking like that. And I think I just wanted to say that, here as well, that ALS has been identified as an illness that is particularly prone to engendering a sense of helplessness and failure, which leads to feeling of frustration and de-skilling that can result in healthcare professionals avoiding patients. And I'm here because I don't want palliative care feeling, no, actually maybe these patients shouldn't be in a hospice setting, maybe they should be somewhere else. So despite all I've said about them, I'm actually advocating that we actually continue to look after them, care for them, because their needs are so specific, so challenging. But we need to be aware of this so that we can look after ourselves in caring for these people. We need to be mindful that the illness causes the difficulties and the challenging behaviour, not the person. I think that's really important. And then just to make everything even more complicated, there's a thing called, and I can't pronounce this, it's anosognosia, where there's a part of the brain that gets damaged, and it results in an inability to recognise the existence of symptoms or disability associated with disease. This is not a deliberate or intentional denying on behalf of the patient. So if you and I get sick, we know we're sick, and you'll kind of, we'll do this. If you've broken your leg, well, you know your leg is broken, and you'll have to rest it, and you have to do this. Well, the part of the brain that you process this is damaged in M&D patients, so they can't work with this. So we're expecting them to process stuff and understand stuff when actually they can't. So I think it's really important to understand these things when we're engaging people. What can we do? We need to understand that the behavioural changes are now recognised, and we know. We need to identify the deficits early. We need to improve communication between us, say, in Beaumont, so-called experts, and letting everybody else know that these patients actually have these. I mean, you guys know this yourself, you're picking it up, so understanding it. We'll have a booklet. I think we need to do more study days. We're going to try and maybe have a day a year in Beaumont, because I think we need to be, sharing this kind of information. We definitely need to increase the support systems for healthcare professionals in community hospitals and hospice settings. And I think sometimes as healthcare professionals, we all have people that we connect with, and we've other people who, gosh, I'd rather not. That's human nature. But actually we need to be kind of careful about our personal boundaries that we put in place, that the people that we connect with, that we don't end up getting drawn in. And they will draw us in, and they'll be very manipulative and very controlling. So we need to put boundaries in place. Another thing that I think is important is that we manage the expectations of the patients and the family. And I have no problem, that we sit down honestly from the beginning and we say to people, these are the services that we have, this is what's available, so that they're not in any, they're not misunderstanding what we can do. Certainly when we say palliative care is going in at the home care team, families think, yay, there's another group coming in, they'll watch Mammy, they'll sit with Mammy. So we are very careful from the very beginning to outline what the service of palliative care is. We need to include the patient and the carers in the decision process. Now, even if the patient can't really understand, I think it's really important to explain why we're doing things so that they understand, and that if we're going to say you have a half an hour and then we're going to go away, if the staff are going to be rotated, this is what we're going to do because this is what the illness does, and it's because of the illness that we're doing that, and include them in things that we're doing. Then we're not being deceitful. As I said, outlined that the disease can sometimes cause these changes, and that the behaviour is challenging and may at times be unacceptable for all concerned endeavouring to provide appropriate care. I think wherever about the manipulation and the control, I actually found some of the racist stuff the most difficult for people to take. I really did, because some of the staff had nowhere to go with that. We say all the time, don't take things personally. And sometimes we don't, and sometimes we can let it go. But if somebody is actually just, because of what you look like or where you come from, so we have to be very mindful to protect staff. Patients and their families need to be aware that their autonomy is not absolute, that they cannot insist on receiving specific, unrealistic or legal treatments. I get back to that again as well. And I think it's really important that we can care for people without abandoning our own integrity. I know that we too have rights sometimes, and we want to come to work, looking forward to come to work. We're working in very difficult, challenging areas, so we don't want to feel that, actually, God, there's nothing worse. And I say to I have two girls, and when they were younger, like you need to get up in the morning and to be looking forward to go to work, whatever you do. That's what we should all have. We bring our best to work then, if that's the case. So we have to be careful, and to feel as well that as a member of staff, wherever your role is, that if you're struggling with a person, that you can go and talk to somebody. I have days if I go into, because I drive all around the country, if I go into somebody's house and they're very difficult, I think sometimes driving back home is I get rid of it. Put on some music and I get rid of it. And I remember a few years ago we had a gentleman in intensive care in Beaumont who was on the non-invasive ventilation, and they wanted to ventilate him and he didn't want to be ventilated, and he wanted to turn it off. And I remember it was a very distressing morning, and I just left work when it was all over because I had enough. It was very sad. And as I was driving home, I was thinking there was one of the intensive care nurses who was with me all morning when we did this. And I rang her back to see if she was okay. And she said to me, oh yeah, I was given an extended coffee break. And I kind of thought, God, I was on my knees. So I did ring the sister and I said, look, I can't function, and I'm sure Mary can't function. So actually they let her go home. But sometimes it's about being mindful of what the impact is on staff. So just a summary around the cognitive stuff. Cognitive and behaviour impairment are intrinsic aspects of MD in some patients, and we need to remember that 50% of MD patients remain cognitively and behaviourally intact, because don't forget, this illness is going to have an impact on people's personalities and behaviour because it's so devastating, the losses that they have, the fears that they have. So we don't want to blame everything on the cognitive stuff. So we just need to be mindful of what's happening. Of those with impairment, early recognition is important. Screening tools are helpful, but it must be used with caution. We know that behavioural changes relates to cognitive and care burden in the healthcare professionals, as well as the carers in healthcare professionals. And I think attributing the behavioural changes to the brain pathology, which is really important, rather than the voluntary conduct of the patient, helps carers and healthcare professionals in changing their emotional response to behaviour. If you know that this person is just not being difficult for the sake of it, that actually they can't help themselves, it may change the way we engage with people. Would you think so? Yeah. And maybe that this will change our negative reactions to more adequate responses, because there's certainly some people over the years, and I thought, no, can't deal, don't even want to go there. But actually, I think I'd like to think I'd be better now. And understanding that the lack of insight, apathy or lack of empathy resulting from brain pathology caused by MD helps caregivers and healthcare professionals to shift their expectations. So from that I just mean that we can't expect them to comply, we can't expect them to agree, we can't expect them to understand the discussions that we have. So we need to remember that.